this computer. Everybody okay with that? Recording in progress. I'm not seeing it actually coming up. I want to make sure that it is it is recording. Yes, it is. Okay, sorry. Because the other day, unfortunately, it didn't record. All right, so very welcome, Stacey. So for anybody who's going to be joining us after the live session, Stacey is a wonderful person who's an assistant professor of psychology in the University of Birmingham, a specialist in sleep and behavioral issues. And Stacey's giving us all of this time, and she's extremely busy. So we are so grateful to you, Stacey. We know that this time is valuable to you, but it's also very valuable to everybody who's going to benefit from your huge expertise. And just for others who may not know, there are already 2 other webinars which Stacey kindly did for us up on the website. So I'll be quiet now and over to Stacey.
Thank you very much. I'm going to be a hypocrite now and tell you everything about what you shouldn't be doing just before bed at this time of night. And one of them is being on laptops and on mobile phones and everything like that because of the blue light. But we'll just forget that this is happening at 8 p.m, pretend that this is a morning session. So some of the slides are going to be a repetition of what I presented in the second webinar, but I think it's just useful to go over what we do know about sleep and its prevalence. So this was a recent meta-analysis, and a meta-analysis synthesizes all of the existing data out there that have included children and adults with tuberous sclerosis complex. And one that I wanted to point out here is the Van Eegen study here in 2011, because that was specifically with adults with tuberous sclerosis complex. A lot of these studies are conducted mainly with children, or can combine a child and adult sample, whereas the Van Eegen paper is a really interesting paper, specifically with adults using self-report questionnaires, and they found excessive daytime sleepiness of 42%. But if we compile all of the existing data that's out there, this is our best estimate of sleep difficulties in TSC. So 52% insomnia, so that's difficulty getting to sleep. Around 46% excessive daytime sleepiness. And the main difficulty when measuring sleep is that when we use questionnaire measures or self-report measures, we're just asking about difficulties with sleep, and we don't really know what that profile of poor sleep looks like. So in general sleep difficulties are around 45%. So we're looking at around half of individuals with TSC will have some difficulties with sleep. And when we think about TAND, so this stands for TSC-associated neuropsychiatric disorders, sleep difficulties falls under the behavioural level of TAND. And it's one of the items that we can measure using the TAND checklist. And I'll also include the self-report TAND checklist that has been recently developed, and I'll show you the items that are specific to sleep that adults themselves with TSC can self-report. Equally on the TAND-SQ, so this is the lifetime version that a clinician should be doing in TSC clinic, but the TAND-SQ that I'll show in the later slides can be completed by an adult themselves with TSC or a caregiver on behalf of their child or adult. When it comes to understanding sleep, and all of us can relate to this, there's a very close association between psychiatric aspects and the profile of poor sleep. So there's a very close association between poor mental health, so any difficulties with anxiety, depression, overactivity, or autism can be associated with the profile of poor sleep as well. And just to drive home this point a little bit, from the TSC registry, where TAND reported data was collected, we can see here which profiles of TAND are more commonly reported in children compared to adults. And what we can see here is that these psychiatric aspects of TAN, so anxiety, low mood, depressed mood, and difficulties in association with schizophrenia, so obsessions and psychosis, these psychiatric aspects of TAND are more prevalent in adults than children. And this is particularly important because we know that there's this association between poor sleep and mental health. So when we see higher rates of anxiety or depressed mood, then we're more likely to see difficulties with sleep, be that insomnia, difficulties getting to sleep, or sleep anxiety. In both children and adults, so going back to that first slide about prevalence, from the TSC registry, which was with 2,000 families, sleep difficulties across the board are prevalent in both children and adults, and it's the second most common profile of TAND after overactivity. So sleep difficulties are something really to look out for in TSC. I've already presented this in my previous webinars, but it's just useful to know that sleep isn't just a flat line in terms of nothing much happens in sleep. We just fall asleep and then we wake up. There's a cycle that happens and sleep stages. And throughout the night, we go through these sleep cycles and these sleep stages. So when we first enter sleep, we're in N1 and N2. So this is light sleep when we're drifting into sleep. N3 is a deeper stage of sleep. And then rapid eye movement or REM sleep is the deepest stage of sleep when we'd be dreaming. And just to point out that there are lots of sleep apps out there. And in general, I would recommend, if you're interested in tracking sleep, there are sleep apps that are freely available, and there are trackers and wearable devices that can be used, that can be bought by anyone in the general public. What I would say is that these give you a good general indication about your duration of sleep. I would say that when it comes to the sleep stages and the sleep cycle, the mobile apps and the wearable trackers don't provide the best estimates. They give you a little bit of a general indication. So I would say that the sleep apps and the wearable devices, if you do have them, by all means use them. But I think they provide a better indication of sleep duration as opposed to sleep quality. I don't think they're accurate enough to be able to tell you when you're entering deep sleep compared to light sleep, for example. So just bear that in mind, that these apps are useful for just some general indication of how many hours of sleep you're getting or how long it's taking you to get to sleep. But I don't think they're as accurate as the medical devices when it comes to understanding the sleep cycles. The other important thing to bear in mind is that our profile of sleep can change over time. And we call this sleep phase disorders. So things can change with age. So in adulthood, compared to the teenage years, for example, in adulthood, we might see as individuals get older, we have an advanced sleep phase, which means we have a preference for going to sleep earlier, but we also wake earlier. So as adults enter older adulthood, they're more likely to get tired a lot earlier than they normally would, but it means they also wake relatively early. So we see a lot more early morning waking with age, and that's just in the general population. Compare that to the teenager or adolescent years when we see the onset of puberty, we see a delayed sleep phase. And again, this is just typical within the general population, but this is exactly what would be happening within adults and adolescents with TSC, that our sleep profile changes with age. So if you're a caregiver of an adolescent, we would see a delayed sleep phase because of the onset of puberty and hormones. We'd see adolescents and teenagers with a preference for going to bed much later and waking much later the next day. And then in some individuals, we can see an irregular sleep-wake, sleep fragmentation. So we most often see this in epilepsy. We see this fragmented sleep profile. And this, we think, coincides with nocturnal seizures, which is a really important issue when we're thinking about TSC. So these are some co-occurring conditions in TSC, and as I've already mentioned, epilepsy is the one that's most prominent, and it's the one that I'm going to focus on. But we also see a profile of intellectual disability in around 50% of individuals, and a profile of ADHD and autism in around half of individuals. So in these co-occurring conditions, regardless of whether or not an individual has a diagnosis of TSC, we would see poor sleep. We would see poor sleep in epilepsy because of the neurological activity causing sleep fragmentation. In intellectual disability, where we see co-occurring physical health conditions, we would see poor sleep. And in ADHD and autism, we would see poor sleep. And in autism, this could coincide with sleep anxiety and sensory preferences. In ADHD, this may coincide with overactivity, behavioural aspects of ADHD, but also medication that's prescribed. So the reason that this is important is because in TSC, there's a lot going on that can affect sleep. So this is a very, very complicated graphic, but it just goes to show you that when we're thinking about any rare genetic syndrome associated with intellectual disability, we'd think about secondary health conditions that may be associated with pain. So in the first instance, we always recommend a physical health check if you see significant changes in sleep, because what might actually be going on is an underlying physical health problem that's resulting in poor sleep. So, for example, reflux or an ear infection is associated with pain, which could be impacting sleep, especially if sleep has been relatively good and then sleep immediately starts to deteriorate. That's when we'd suspect that physical health may be playing a part. And the aspects that are most prominent to focus on within this presentation for TSC is thinking about whether seizures are taking place overnight, which are affecting sleep in terms of sleep fragmentation or number of wake-ins overnight, or the quality of sleep, so waking up as if you're not well rested because of the level of brain activity from nocturnal seizures. But also thinking about the effects of anti-epileptic medications, which have known sedative side effects that cause drowsiness. And then alongside all of this, so you've got all of these biological aspects, thinking about secondary health conditions that may be associated with pain, the presentation of epilepsy, for example. Here we'd be thinking about hormone imbalance, so maybe thinking around the adolescent years, that imbalance of hormones during puberty. Alongside all of that, we've also got mental health presentations and psychiatric diagnoses, so whether or not co-occurring autism and ADHD are diagnosed, whether an individual also presents with anxiety or depression, and alongside their anxiety and depression are prescribed medications for these mental health conditions, which have known side effects that affect sleep. So it's a very complicated picture is what I'm trying to say. Sleep in itself is very complicated. There are lots of peaks and troughs in terms of the profile of sleep changing with age, the profile of sleep changing with the presentation of co-occurring health conditions, the presentation of sleep changing when we're thinking about medications that are prescribed, the profile of sleep changing when we're thinking about mental health conditions and medications, and the multitude of medications for both epilepsy and mental health when it comes to TSC. So just to really emphasize this point, when someone is struggling with sleep who has epilepsy, this actually lowers the threshold for increase in seizure frequency. So there's this really intense relationship, I guess, between sleep and epilepsy. When someone's not sleeping well, their threshold for seizures decreases, which increases seizure frequency. And then it becomes locked into a cycle. If someone's not sleeping, the threshold for seizures decreases. They have more seizures that can result in daytime sleepiness, that can really shift their sleep pattern. They may be sleeping more or less. They may be sleeping more in the day, less at night, having more nocturnal seizures that's affecting their sleep quality, which means they're waking earlier. And so this can really disrupt our physiology when it comes to understanding the association between sleep and epilepsy. And this disturbed sleep can have massive implications for an individual's quality of life. So if we're thinking about schooling, work, friendships, relationships, this can have a massive impact. If someone doesn't feel well rested, if they're having more seizures, their medication is changing, they're feeling groggy and drowsy because of the side effects of medications. It's a really, really difficult cycle to monitor, I guess. And so this is the recommendation in terms of maintaining sleep or improving sleep for individuals with epilepsy. So I'll go on to talk about this measure in a bit more detail to show you what the items actually look like, and it's freely available online. It's called the Epworth Sleepiness Scale. So if the person you care for, or if you self-report poor sleep, you can fill in this questionnaire, which is just 8 items, which asks you about certain scenarios and how drowsy that individual may be. What's the likelihood that they'd fall asleep? And a score of 10, a 10 to 12 is used to indicate borderline daytime sleepiness. A score of 12 and above is used to indicate excessive daytime sleepiness. And any professional, any sleep practitioner, any medical professional in the first instance would recommend sleep hygiene. So sleep hygiene it sounds really condescending when we talk about sleep hygiene for some parents and some adults themselves, when we're talking about all of these things that maintain good sleep. So you think about minimizing your access to electronic devices in the hour before bed. It's all about setting up the bedroom to have a conducive sleep environment, making sure that it's very dark and very cold. It's all about the environment and creating an environment that's suitable for sleep. So maybe not having a TV in the bedroom, not completing work or schoolwork in the bedroom. And sleep hygiene is always the approach that's recommended first. So as much as possible, as a caregiver or as a person yourself who can self-report with TSC, it would be really, really important to document all of the things you do to maintain good sleep hygiene. Because if it gets to the point that sleep is particularly bad, the first block you will face to get seen for further assessment would be keeping a sleep diary and trying to defend your sleep hygiene strategies. So if you go to that first appointment having already got a very clear record of all of the things you do to maintain sleep hygiene, and you keep a sleep diary for at least 2 weeks, they really can't put on a block to transfer you to the next step to improve sleep. So that's what I would say as a baseline. Have a good, clear record of what your sleep hygiene strategies are and that you're enforcing them within the home environment, and keep an accurate sleep diary for at least 2 weeks. Because what a medical professional would then recommend, if there's good evidence that sleep hygiene is in place and it's not working, would be to rule out nocturnal seizures, or to assess in an overnight sleep clinic what the profile of sleep is. So this is an overnight EEG using video polysomnography. That's what this stands for. So this would involve you or the person you care for staying overnight in a sleep clinic where the overnight sleep behaviour is also monitored. So it would be EEG and other monitors of health, so blood pressure, heart monitors, and EEG. It's quite an intense setup in a sleep laboratory. And usually it involves 2 nights staying overnight in the sleep laboratory. But this is the gold standard for measuring neurology and seeing what's going on in the brain in terms of nocturnal seizures, and then also recording via video if there's any indication of nocturnal seizures or other health aspects associated with poor sleep. So, for example, obstructive sleep apnea. So if the person that you care for, or if you snore very heavily, that could be an indication of obstructive sleep apnea, for example. If at that point you've highlighted what your sleep hygiene strategy is, you've kept a sleep diary within the home environment, you've taken part in an overnight sleep study in a sleep clinic, if we still see excessive daytime sleepiness, the next step would be the person involved in your care thinking about anti-epileptic medications and the side effects of anti-epileptic medications, and considering changing the dose or changing over to another anti-epileptic medication that's not associated with the side effects that we would see, where we would see excessive daytime sleepiness. So for all of this to happen, they'd have to have a medical review of all of the medications, because there's a massive crossover between poor sleep and medications that are prescribed for mental health conditions such as anxiety and depression. So as I've already mentioned, maybe the first step, if you are concerned about poor sleep, is actually completing the Epworth Sleepiness Scale, either for the person that you care for or self-reporting. What would be the chance of dozing in these 8 scenarios? And all you do is add up the score. A score of 10 to 12, as I've said, indicates borderline daytime sleepiness. 12 and above would indicate excessive sleepiness. And then that would prompt the person involved in your care to think about your sleep hygiene strategies. They would recommend completing a sleep diary, and then they would look into this overnight sleep assessment in a sleep clinic. If daytime sleepiness is excessive and it has been prolonged and it is different to what has been typically reported in the past. And so these are the most commonly prescribed medications in tuberous sclerosis complex. And this is an international study. And in red here, you can see what the first choice would be for focal seizures, for example. And so here are some common anti-epileptic drugs that are prescribed in tuberous sclerosis complex, and I've highlighted the ones, like I say, some have are different for children and adults in terms of how commonly they're prescribed, so vigabatrin, for example. But as you can see, there are a number of anti-epileptic medications, so topiramate, for example, that are associated with drowsiness and sedative effects. And actually at the very bottom, they say that all of the medications, all of the anti-epileptic medications can cause drowsiness. And then benzodiazepines, which are commonly prescribed for mental health conditions, can also be associated with sedative effects, drowsiness and excessive daytime sleepiness. So what would commonly happen at your first review about poor sleep would be keeping a sleep diary, talking about sleep hygiene strategies, but then alongside that, there should be a review of medication and what current medications are prescribed. So I don't think I need to dwell on this point too much longer, that there is a cycle between not only sleep and epilepsy, where you can get locked into that cycle of poor sleep leading to a lower seizure threshold, which increases the likelihood of seizures happening, which has a knock-on effect of the next day's excessive daytime sleepiness, poor sleep, and so the cycle continues. We also see a negative feedback cycle for sleep and mental health, where worrying about getting to sleep or worrying about how little sleep you're getting overnight, or being anxious about going to sleep or not being able to settle to sleep, or being anxious because you know that by the time you go to bed you're not going to be tired and that you're going to have insomnia and that you're going to wake up the next day not well rested, not having had a good night's sleep, can have this negative feedback loop where the stress and worry about sleep affects sleep, you don't sleep, and it affects your next day. And so this cycle of feeling really irritable, not sleeping well, not eating well, having difficulty concentrating, sleeping at inappropriate times if you're having to have a mid-afternoon nap, can all perpetuate this cycle of poor mental health when you're not sleeping well. And as I've presented in the previous webinar, there's also a close relationship between sleep and eating behaviour. So when we're not sleeping well, we crave sugary, high carb foods, which means we're more likely to snack in the day, we're less likely to eat nutritious foods, which can again have a knock-on effect on our energy levels, which means we're energetic at inappropriate points in the day. If we're relying on caffeine too much in the day, it means that we can have trouble sleeping at night. So in our Eat Sleep Cluster recommendations, as part of the Tandem project, here's just some, like I say, these don't mean to sound condescending around sleep hygiene, but it's just important to bear in mind that you're showing that to your healthcare providers or professionals that you're already aware of all of the things that are associated with sleep, and that you're sort of tackling the basics when it comes to sleep hygiene, because it's always the first things that professionals would be asking about. So just some simple things to do is to just limit the access to sugar and sugary drinks and caffeine in the run up to bedtime. And also that the timing of exercise is important. So we wouldn't recommend doing intense physical activity, cardio, exercise in the few hours before bed, but we would recommend physical exercise and activity in the late morning or early afternoon. So in the recently published consensus guidelines for TAND, these were our recommendations specifically for sleep difficulties. And I've already gone through these in some detail, but it's everything that we talked about in terms of sleep being very complicated in terms of its associations with pain, with underlying health conditions, with the presentation of seizures, with the presentation of daytime behaviour. And so there's this, we call it a bidirectional association, and it's essentially that cycle that we're talking about, that poor sleep can affect all aspects of daytime functioning in terms of attention, eating behaviour, health, mental health, and that this can lead to a very vicious cycle where this then has a knock-on impact on the ability to get to sleep and have high quality sleep. In the very first instance, professionals and caregivers should be thinking about those biological health conditions and underlying factors that may be associated with poor sleep. So again, this is particularly important if you see a very sudden transition in the quality or quantity of sleep that deviates from what is typical for the person you care for, or deviates from your typical profile of sleep. So you may wish to think about a change in seizures, or whether there's underlying pain or underlying health conditions, or whether there's a new medication that's having a knock-on effect in terms of poor sleep. So after all of those biological factors have been ruled out, as I've already said, when you see a medical professional or the person who coordinates your care, they will always advocate for sleep hygiene and environmental changes that you're making to the sleep environment. So they'll be thinking about sleep education programs, sleep hygiene practices, before they would consider any pharmacological changes or refer you to an overnight sleep assessment in a sleep clinic. And so the TAND-SQ, the self-report version, so at the very start of the presentation, I presented the lifetime version of TAND, which should be completed in a clinic by a clinician. The TAND-SQ is a self-report version. And so this is really useful as a caregiver or as a person yourself, tracking how sleep has changed or whether any difficulties have changed within a period of a month or 2 months or 6 months. And this is just a really simple 0 to 10 rating scale that allows you to track difficulties with sleep. And when we developed the TAND-SQ associated with this, if individuals do mark themselves highly for having sleep difficulties, is we developed a TAND toolkit. And so I'm just going to present some of the information from the TAND toolkit, which is specific to adults and caregivers of adults. So I do sound like a broken record, but in the very first instance, if you're concerned about sleep, you will always be told to keep a sleep diary. And the QR code links to an NHS sleep diary that's freely available online, which is a very good record of all of the factors that are associated with sleep and the table that you should use to track sleep. And it's recommended you keep a sleep diary for around 2 weeks. So what's really important to track alongside not just how long did it take to get to sleep, how many wakings during the night were there, what was your mood upon waking, what was your medication dose for a given night. It's always also important to track how the individual feels or how you behave or other aspects relating to mental health and eating behaviour as well. In terms of identifying nocturnal seizures, I'm always quite cautious about presenting information relating to seizure alarms or having seizure alarms under the mattress or triggers within the bedroom in terms of the door, because I know that a lot of families say that this would just be constantly buzzing and that wouldn't be manageable in a home setting. But what might be useful, especially if there is a significant period of sleep, if you do have access to simple infrared video recording equipment, that you may wish to record behaviours overnight, just to see how often an individual wakes or what your behaviours are like during sleep. So whether there are thrashing behaviours that could be indicative of nocturnal seizures. In terms of, as I've already mentioned, mobile apps can be informative to an extent, but I would say that they're better at giving a general overview of overall sleep duration as opposed to accurately tracking the sleep cycles or the sleep stages. I was really curious whether anyone online or anyone who watches the recording back has ever used any of these wearable epilepsy sensors, just because I'm curious about how effective they are at tracking nocturnal seizures. So if anyone has used these wearable wristwatch epilepsy sensors, I'd be really keen to hear how they've gone down. And then if nocturnal seizures are identified, your medical professional, the neurologist involved in your care, should provide medical consultation in terms of changing medication or reviewing anti-epileptic medication if nocturnal seizures are detected. And again, I'm not going to spend too much time on this because it does always sound quite patronizing when I'm outlining what we mean by sleep hygiene, because a lot of the time people are already doing this, or caregivers are already following these guidelines. But it's just important to note, because these are the things that the doctors will make sure are in place before they refer for any further follow-up when it comes to sleep. So a consistent bedtime routine, even on the weekend. The exception for this, I would say, is with very frequent, constant seizures. I would never discourage a person from having a nap or catching up on sleep when they've had a period of very frequent, constant seizures. Bedrooms should be set up to support sleep, so they should be dark and they should be quiet. As I've already said, excessive physical exercise in the few hours before bed isn't recommended, but exercise during the day is recommended in terms of sleepiness later at night. You should limit access to electronic devices and screens. For individuals who are quite sensory, removing labels from bedding and pajamas, thinking about the texture and weight of things, for those who are particularly sensory, could be helpful. Blackout blinds and noise cancelling headphones could be beneficial, again, for those who are sensory to light and noise. And we would recommend the use of wireless headbands and headphones for those who do have nocturnal seizures, in terms of a risk of injury from the wires. So I hope that's been useful. I do feel like I'm preaching to the choir when I talk about sleep hygiene strategies and anti-epileptic medications, but I hope that was helpful.
Thank you so much, Stacey. It was really helpful. There was somebody else online. They don't seem to be visible anymore. Chris, did you have any questions? You're on mute.
Okay.
Now we can hear you.
Nocturnal seizures. If there's not a seizure at nighttime, sleep is good. But when there's a seizure at nighttime, they might not sleep for 24 hours.
I'm so sorry. My sound is really bad. It sounds really crackly. Let me just put my headphones in. Sorry. Hello?
Yeah, can you hear me?
Hello?
Yeah.
I can hear you. Can you hear me?
Yeah, sorry. My laptop speaker went really, really crackly.
Yeah, no
Sorry,
problem.
could you say that again?
Nocturnal seizures.
Yeah.
Under normal circumstances, no seizures, sleep is perfect. If they have a nocturnal seizure, they might not sleep for 24 hours afterwards. Have been given diazepam. Sometimes works, sometimes doesn't work. So, any recommendations or who we should see?
So it would always be neurology who are involved if it's, so there were no seizures in the day.
Very few.
Few seizures in the day, but it's, and how, if you don't mind me asking, how are you monitoring the nocturnal seizures? Is it quite obvious that they're
It's quite
happening?
obvious. It's usually tonic, clonic. You see,
Okay, yeah. So, and do you video record those?
no, at the moment, no, because we have shown these to the neurologist already.
Okay.
So, and it's usually in if she's asleep for more than 2 hours, it's not going to happen. It's always in the kind of the first 2 hours of sleep. So a light sleep would it be? I don't know.
So again, not to preach to the choir, but if you could keep a sleep diary to just track what's going on the days where you see a nocturnal seizure and compare them to the days that you don't, in terms of medication, behavior, mood, health, all of those things, and just keep a track of, just keep it for, 4 or 5 days where you'll see a nocturnal seizure compared to ones where you don't. It might indicate whether there's something going on in terms of things that have happened during the day, or whether there's been more seizure frequency, the odd seizure that's happening in the day that could be a bit of a marker for whether there'd be a nocturnal seizure.
Okay.
And then, sorry.
Would there be a reason why they don't sleep after the seizure?
That's a really tricky one. So I'd be really keen. So my next study, hopefully, is going to be with adults themselves who can self-report what they experience from nocturnal seizures and how it affects them the next day. So yeah, that's actually going to be my next study, is to do these interviews with adults with TSC who have frequent seizures and poor sleep, to try and understand a little bit what their experiences are in terms of their mood, and whether they have, like migraines, headaches, whether they feel really out of sorts the next day. So yeah, that's I'm really sorry I don't have any
Yeah, no problem.
indication.
And Stacey, before I let you go, I just have one question, because when I was looking at that cycle, that slight cycle, like if you take a nap, then you're going to be out, you're trying to recuperate something, but you've got this vicious cycle. Have you any tips for breaking that cycle?
So this is where it's, when it comes to napping, but for any child of school age and for any adolescent and for any adult, naps generally aren't recommended, apart from like a short 30-minute nap if you really, really need it. But there's something called a sleep debt, where if you're not sleeping, you need to recover your sleep. So if you say 8 hours is typical, and then you've gone 3 or 4 days with only 4 hours sleep, that's not enough to survive on. And so you have a sleep debt where you need to recuperate that lost sleep. And so you could, and people with epilepsy or health conditions that affect sleep will talk about this recovery period, which is why I'm a bit reluctant to completely rule out naps, because it all depends on what's appropriate for someone's context. I would never tell someone not to have a nap if they've gone for a week having horribly disrupted, fragmented sleep, because they've got a sleep debt and they need to build up that sleep back. However, if it's this cycle of poor quality sleep, and it's become, having a nap has been quite consistent, and you actually want to eradicate it because it's become more of like a behavioral habit as opposed to something that you actually really need to counteract your sleep debt, then there are lots of behavioral techniques that you can use. So you can just use something like nap fading, where you just sort of wean yourself off a nap. So still allow yourself a nap, but you just sort of reduce the duration of the nap until you can eradicate it.
Okay. But thank you. Thank you so much. And Christy, no other question?
Just a clarification, Stacey. Did you say the room should be cold to get sleep?
Yeah, it should be dark and cold.
Cold, okay.
Yeah. So like, obviously we wouldn't say like not to have a duvet or anything like that, but yeah. An open window, if you're not too sensitive to sound, it should be quite cold.
All right, okay.
Yeah.
Well, we don't have any problem these days with that. Okay, Stacey, listen,
Nice
thank
to
you
see
so,
you
so
both.
much. This has been wonderful. So I'll stop the recording and thank you.
That's all right.
Let me finish.